You know, when you hear about something silent, lurking in the body, that could suddenly become a really huge problem.
Yeah, those hidden dangers.
Exactly. And today, we're plunging into one just like that, abdominal aortic aneurysm, AAA for short.
Right.
So imagine the main pipe carrying blood down through your belly, that's the aorta, and it develops a weak spot, kind of balloons outward.
That's the gist of it, yeah. And AAA.
And the scary thing is it often just flies under the radar, no symptoms.
Until it doesn't. If it bursts, it's incredibly serious, a real life or death situation.
So think of this deep dive as your sort of streamlined guide. We want to get you clued up on AAA for revision, really zeroing in on what matters most.
Definitely. We're working from the Abdominal Aortic Aneurysm Overview revision notes. Our mission here is basically to pull out the absolute must-know info for you.
Everything from what it is to the risks, how it happens, right through to managing it, and area of potential problems down the line.
The whole picture, yeah. Definition, causes, risks, pathophysiology, differentials, who gets it, how it shows up, investigations, management, prognosis, and complications. All of it.
Okay, brilliant. Let's get straight to it then. What exactly is an aneurysm in the first place? Just the basic definition.
Okay, so simply put, an aneurysm is a permanent widening of a blood vessel.
Permanent.
Yeah, permanent and irreversible. And it has to widen by at least half its normal size, so 50% or more.
Gotcha. And we're talking specifically about the one in the abdomen, the abdominal aorta.
Exactly. And what's happening deep down, like at the tissue level, is the aorta wall is losing its strength. It's becoming less elastic.
Like an old rubber band.
Sort of, yeah. It doesn't snap back. There's a breakdown of these stretchy elastic fibers, some inflammation, you get white blood cells involved, and there's more activity from enzymes that break down proteins, plus you lose some of the smooth muscle cells that keep the artery wall strong.
Wow. Okay, so it affects the whole structure.
It can, yes. All the layers of the artery wall could be involved.
So what's the magic number then? You mentioned 50% widening, but what's the actual size? When does a normal aorta become an aneurysm?
Right. So a typical abdominal aorta is roughly about 2 centimeters in diameter.
Okay.
We officially call it an aneurysm when it reaches 3 centimeters or more.
3 centimeters, right. And where do these usually happen?
Well, interestingly, the vast majority, maybe 95% or so, occur below the point where the arteries branch off to your kidney.
Below the renal arteries. Okay.
But we should probably also mention thoracoabdominal aneurysms quickly. They're less common, but span both the chest and abdomen.
And they could affect blood flow to other organs.
It can, yeah. Potentially the gut or the kidneys. And it's also worth knowing if you have an aneurysm somewhere, you're a bit more likely to have one elsewhere in the body.
Okay. And size matters here.
An absolute
Right.
crucial point.
Yeah.
Larger AAAs tend to grow faster. And here's something really important. The risk of them rupturing, actually bursting, is significantly higher in women than in men for the same size aneurysm.
That is important. Really key difference to flag. So moving on, what actually kicks off this whole weakening process? What are the causes? The etiology?
Yeah, this is where it gets a bit tricky because, honestly, we don't know the single precise cause. It's likely a combination of things.
Okay, but what are the main players, the contributing factors?
Well, severe atherosclerosis is a big one. That's the hardening and furring up of the arteries with fatty deposits.
Right, atherosclerosis.
Then there's definitely a genetic link. If it runs in your family, your risk goes up.
Family history, okay.
Certain connective tissue disorders, too. Things like Marfan syndrome, which affect the body's structural proteins, can weaken the aorta.
Makes sense. Anything else?
And less commonly, certain infections or inflammatory conditions might play a role.
Okay, so those are the sort of underlying contributors. What about the really clear risk factors, the things we can easily list and remember for exams?
Absolutely. For easy recall, you could think of the mnemonic AGETHATS.
AGETHATS. Okay, break that down for us.
Right, so A is for age. Being over 65 is a major risk. G is for gender. It's much more common in men.
Okay, AG.
E is for every puff counts tobacco smoking.
Okay.
This is a huge one. Smokers are at much higher risk.
Right, smoking is key. ET.
H is for history. That's family history of AAA. A is for artery hardening, which is atherosclerosis again.
HA.
T is for tension high, so hypertension or high blood pressure. And the final S is for those less common situations like the connective tissue disorders or infections we mentioned.
GET, HATs. Age gender, every puff tobacco, history, atherosclerosis, tension, hypertension situations. That's quite helpful.
Hopefully. So basically, older men who smoke and have high blood pressure or a family history, they're the ones at highest risk.
Got it. So we know the risks. How does it actually progress? Can you walk us through the pathophysiology, like step by step?
Sure. So you've got those risk factors and the cellular changes we talked about, the breakdown of fibers, inflammation, all that. It starts to weaken the wall of the abdominal aorta.
Makes it less springy.
Exactly. Less elastic. Now, think about the constant pressure of blood pumping through it day in, day out. That pressure pushes on the weakened section.
And it starts to bulge outward.
Precisely. It forms that bulge, the aneurysm. And over time, if nothing changes, this bulge just tends to get bigger and bigger.
And the bigger it gets,
the more tension there is on that already weakened wall. And that's what really ramps up the danger of a rupture, a complete tear, or something called a dissection, which is a tear within the layers of the artery wall itself.
So it's this gradual stretching and weakening that can lead to a catastrophe.
That's the process, yeah. Slow burn towards a potential critical event.
Okay, now sometimes symptoms like back or abdominal pain might crop up. How do doctors differentiate AAA from other things? What's on the differential diagnosis list?
That's a really crucial clinical point, because an unruptured AAA is often silent, right? So if someone does get symptoms, they can easily be mistaken for other, much more common conditions.
Like what?
Well, for abdominal pain, you'd think about kidney stones, gallstones, maybe diverticulitis or other gut problems. For back pain, it could easily be musculoskeletal, a slip disc, muscle strain.
Standard back pain causes.
Exactly. Then you also need to think about other vascular issues. Aortic dissection is one, but that's usually a much more dramatic, sudden tearing pain. Or maybe an aneurysm in the iliac arteries down in the pelvis.
So it's about putting the symptoms together with the risk factors.
Absolutely. You have to consider the whole clinical picture. Is this an older male smoker with sudden back pain? Then AAA needs to be high on your list of possibilities to rule out.
Makes sense. Okay, let's zoom out again. Who actually gets AAAs? What's the epidemiology look like, especially here in the UK?
Right. In the UK, it's definitely a condition predominantly affecting older adults. And as we said, significantly more common in men.
We have numbers on that.
Yeah, for UK men age 65 and over, the estimated prevalence is around 1.3%.
1.3%. Okay.
But remember that point about women. While fewer women get them, their risk of rupture is much higher if they do.
That's why screening is targeted, isn't it?
Exactly. The NHS has a national screening program where all men in England are invited for a free ultrasound scan in the year they turn 65.
Just a simple ultrasound?
Yep. Quick, painless. And the whole point is to catch these aneurysms early when they're small and can be monitored or managed before they become dangerous.
And does the screening pick up many?
The prevalence found in that screened population is also around that 1.3% mark. Interestingly, there's some evidence that the overall prevalence might be slowly decreasing over time.
Why is that?
Likely due to reductions in smoking rates, which is great news.
Definitely. Okay, screening is key. But how might an AAA actually present if it's not picked up on screening? What are the clinical features we should look out for?
We should think about it in two main ways: unruptured versus ruptured.
Okay, unruptured first.
Right. The vast majority are completely asymptomatic. Silent. People have no clue. They're often found completely by chance. Someone has a scan for kidney problems or back pain, and, oh, look, there's an aneurysm.
The incidental finding.
Exactly. But sometimes an unruptured one can cause symptoms, though they're often quite vague. Maybe a persistent ache deep in the back, or the abdomen or the side of the loin area, or even down into the groin.
An ache. Anything else?
Occasionally, if it's large enough, someone or a doctor examining them might feel a pulsating mass in the abdomen when pressing gently.
You can actually feel it pulsing.
Sometimes, yeah. Less commonly, you might get signs of tiny clots breaking off from inside the aneurysm and traveling down to block blood flow in the legs. That's called distal embolization, causing limb ischemia.
Reduced blood flow to the legs.
Yeah. And very rarely, a large aneurysm might press on the ureter, the tube draining the kidney, causing it to swell up. That's ureterohydronephrosis. Or trigger some local inflammation or scarring behind the abdominal cavity called retroperitoneal fibrosis. But these are less common presentations.
Okay, so mostly silent, sometimes vague pain or a pulsating feeling. Now, what about the really serious one, the ruptured AAA?
Right. This is the absolute emergency. Ruptured AAA should be suspected in pretty much any patient. especially an older one with risk factors, who presents hypotensive low blood pressure with unusual abdominal or back symptoms.
What are the classic signs?
The classic triad, though not always present, is sudden, severe abdominal or back pain, often described as tearing, then syncope, fainting, or collapse, and signs of shock, low blood pressure, fast heart rate, pale, sweaty.
Pain, collapse, shock.
Yeah. On examination, you might still be able to feel that pulsating mass, but maybe not, especially if the patient is larger or has a lot of guarding due to pain. Palpation is less sensitive in people with a larger waist circumference.
Okay. Any other signs?
You might sometimes hear an abnormal whooshing sound over the abdomen with a stethoscope that's called a bruit. And remember, the signs can vary. If the rupture bleeds into the space behind the peritoneum, you might see bruising appear on the flanks later on. That's called Gray-Turner's sign.
Gray-Turner's sign. Okay, that's a key one for retroperitoneal bleeding. So if a doctor suspects in AAA, ruptured or unruptured, what tests do they order? What are the investigations?
The absolute mainstay for screening, and often the first test for diagnosis if someone isn't critically unwell, is an abdominal ultrasound.
Quick and easy.
Yeah, it's non-invasive, no radiation, readily available. It's great for detecting an aneurysm and measuring its size accurately, usually within about 3 millimeters.
And if they find one, or if it's an emergency?
Then a CT scan is usually the next step, especially if rupture is suspected or surgery is being considered. CT gives much more detail, the precise size, the exact location relative to the kidney arteries, whether there's any clot inside, if it extends up or down, any signs of leaking or rupture.
What about blood tests?
Oh yeah, definitely. Blood tests are vital. You need a full blood count check for anemia from bleeding. Clotting screen essential before any potential surgery. Kidney function, UNEs or urea electrolytes, and liver function tests. Inflammatory markers like ESR and CRP might be raised, and crucially, group and save or cross-matching blood in case a transfusion or emergency surgery is needed.
Standard pre-op bloods, basically.
Pretty much. And depending on the patient's overall fitness and other health problems, you might also get an ECG to check the heart, maybe a chest x-ray, and possibly lung function tests if they have respiratory issues.
And you mentioned CT angiography.
Yes, CT angiography or CTA. That involves injecting a contrast dye during the CT scan. It lights up the arteries beautifully and gives a really detailed roadmap. It's crucial for planning surgery, especially the endovascular type, EVA, as it shows the anatomy very clearly, like the neck of the aorta just below the renal arteries where the stent needs to seal. It's also used if rupture is suspected and the patient is stable enough for a scan before potential repair.
Right, that detailed map makes sense for planning. Okay, so we found in AAA. What happens next? How is it managed?
Management really hinges on a few key things. The aneurysm size, is it growing, and how fast is it causing symptoms? And what's the patient's overall health and fitness for potential treatment?
So it's not always surgery straight away?
Oh no, definitely not. For smaller aneurysms, the approach is usually surveillance watchful waiting with regular scans.
How regular?
It depends on the size. Generally, if it's between 3.0 and 4.4 centimeters, an annual ultrasound scan is recommended. If it's a bit larger, say 4.5 to 5.4 centimeters, then surveillance is usually more frequent, typically every 3 months with ultrasound.
And if it hits 5.5 centimeters?
That's generally the threshold, yeah. At 5.5 centimeters or larger, the risk of rupture starts to significantly increase. So surgical repair is usually considered for patients who are otherwise reasonably fit, though some might still be monitored closely every 3 months initially, especially if surgery carries high risks for them.
Okay, so surveillance for smaller ones. What else is involved in management besides scans?
Medical management is crucial, whatever the size. This is all about tackling those underlying causes and risk factors we talked about earlier.
Smoking.
Absolutely, number one.
Yeah.
Smoking cessation. Stopping smoking is probably the single most important thing someone can do. Then, tight blood pressure control is vital.
Bringing that hypertension down?
Exactly. Statins are usually prescribed to manage cholesterol, even if levels aren't super high, as they might have other benefits for the artery wall. And often, low-dose aspirin or another antiplatelet drug is given. Although the evidence for preventing AAA growth isn't super strong, it's good for overall cardiovascular health.
And are there any specific drugs being looked at to stop them growing?
There's ongoing research, yeah. Things like certain antibiotics, macrolides, metformin, a diabetes drug, and tranexamic acid, which mimics clotting, have been investigated, but nothing's proven definitively effective enough to be routine practice yet. So the focus remains on risk factor control and surveillance.
Right. So medical management and monitoring. When does surgery definitely come into play? You mentioned 5.5 centimeters.
Yeah, 5.5 centimeters is the main size threshold for considering elective repair in fit patients. But there are other triggers too.
Like?
Well, obviously, if it ruptures, that's an emergency operation. Also, if an aneurysm is growing very quickly, say more than 1 centimeter per year, that's often an indication for repair, even if it's not yet 5.5 centimeters. And if an aneurysm becomes symptomatic, causing that persistent pain or tenderness we mentioned, that's usually another reason to operate, regardless of size.
Pain means it's unstable.
It can suggest it's becoming unstable or expanding, yeah. So size level 5.5 centimeter rupture, rapid expansion, or symptoms are the main indications for repair.
And what types of repair are there?
There are two main approaches. The traditional method is open surgical repair.
Big operation.
It is, yeah.
Yeah.
It involves a large incision in the abdomen. The surgeon clamps the aorta above and below the aneurysm, cuts the aneurysm open, and sews in a synthetic tube graft, usually made of Docrin or PTFE, to replace the weakened section.
Replaces the pipe, basically.
Exactly. The second main option, which is more common now for elective repairs, is endovascular aneurysm repair, or EVR.
That sounds less invasive.
It is. It's done via small incisions, usually in the groin. The surgeon inserts a collapsed stent graft, which is like a fabric tube supported by a metal scaffold, through the femoral arteries in the legs.
Up into the aorta.
Yep, guided up using x-rays. Once it's in the right position spanning the aneurysm, the stent graft is deployed. It expands and seals against the healthy aorta wall above and below the aneurysm. Blood then flows through the graft, taking the pressure off the weakened aneurysm sac.
So the old aneurysm sac is still there, just bypassed.
Exactly. It's excluded from the circulation and should hopefully shrink over time. But EVAR isn't suitable for everyone. You need the right anatomy, particularly a good length of healthy aorta below the kidney arteries, the neck, for the stent graft to seal properly.
So how do they choose between open surgery and EVR?
It's a complex decision. Factors include the patient's age and overall health. EVAR is generally less physiologically stressful than open surgery, so it might be favored in older or less fit patients.
Makes sense.
The specific anatomy of the aneurysm is key. Is there a suitable neck for EVAR? Are the access arteries in the legs okay? Sometimes open surgery is needed if there are other problems in the abdomen that need addressing at the same time. Patient preference also plays a role.
And complex cases.
Complex EVAR, like needing branched or fenestrated grafts to preserve flow to kidney or gut arteries, is often done in specialized centers, sometimes within research trials. But for standard elective repair, EVAR is often a first consideration if the anatomy is suitable.
And after the repair, is that it? Job done?
Not quite. Lifelong surveillance is needed, especially after EVAR.
Why is that?
Because there's a small risk of complications later on, like the graft moving or leaks developing around it called endoleaks, which could repressurize the aneurysm sac. So regular follow-up scans, often contrast-enhanced CT or a specialized duplex ultrasound, are essential to check the graft is still working properly.
Right, ongoing checks are key. So overall, what's the outlook for someone diagnosed with an AAA? What does the prognosis look like?
It really varies. The main factors are the size of the aneurysm when it's found, how quickly it's growing, and crucially, the patient's other health issues, their comorbidities.
Smaller ones are safer.
Generally, yes. Smaller aneurysms have a much lower annual risk of rupture compared to larger ones. The risk really starts to climb steeply once they get over 5 or 5.5 centimeters. So early detection through screening or incidentally finding them when they're small is hugely beneficial.
And how fast do they grow, typically?
On average, smaller to medium ones, say less than 5.5 centimeters, tend to grow relatively slowly, maybe around 0.2 to 0.3 centimeters per year on average. And it's a big. But growth rate can be unpredictable, and larger ones tend to grow faster. Plus, having a AAA means you likely have widespread atherosclerosis, so the patient is at higher risk of heart attack and stroke anyway.
Okay. What about survival after repair?
For elective repair, the 5-year survival rate is pretty decent, around 70% overall. But again, this is heavily influenced by the patient's age and other health problems. Someone with severe heart, lung, or kidney disease will have higher risks during and after the operation and poorer long-term survival.
And if they don't have surgery for a large aneurysm?
If an aneurysm is large, say over 5 centimeters, and isn't repaired, the prognosis is unfortunately very poor. The annual survival rate is estimated to be only around 20%. The risk of rupture is just too high.
Wow, only 20%. And if it does rupture?
Then the outlook is extremely grim. Overall mortality for a ruptured AAA is about 80%. Even for those who make it to hospital and undergo emergency surgery, the mortality rate is still tragically high, around 50%.
50% even with emergency surgery?
Yeah. It just highlights how devastating a rupture is and why preventing it through screening and elective repair is so important.
Really underscores the value of that NHS screening program for men at 65.
Absolutely. Finding them early makes a massive difference.
Okay, finally, besides rupture, what are the other potential complications that can arise from having a AAA?
Rupture is the big catastrophic one, obviously, leading to massive internal bleeding and shock.
Right.
Another serious, though less common, vascular complication is aortic dissection, where you get a tear in the inner lining of the aorta wall itself. That's also an emergency.
Okay.
Then you get peripheral embolization. Little bits of clot or debris lining the aneurysm wall can break off and travel downstream.
Blocking smaller arteries.
Exactly. Most often to the legs or feet, causing sudden pain, coldness, or even tissue death, ischemia, or gangrene. It can also go to the kidneys or gut.
Nasty. Anything else?
Well, the aneurysm itself can cause problems by pressing on nearby structures, as we mentioned with the ureter, and very rarely an aneurysm can become infected, forming an abscess within the aortic wall, which is called a mycotic aneurysm. It's very serious, too.
Okay, so rupture, dissection, emboli, ischemia, infection, quite a list.
It is. They're not all common, but they're potential serious consequences.
So wrapping this up, the big takeaway seems to be that AAA is a really serious condition, often totally silent, which makes awareness and, crucially, screening in those high-risk groups, older men, smokers, so incredibly important.
Absolutely. Catching it early, monitoring it appropriately, managing risk factors, and intervening with repair at the right time can dramatically change the outcome and prevent that devastating rupture.
It really makes you think, doesn't it, given how silent AAA often is and how effective screening seems to be? Well, what are the broader implications, for public health trying to detect other asymptomatic but potentially lethal conditions?
That's a really interesting question to ponder, isn't it? Where else could targeted screening make such a difference? Food for thought.
Definitely. Well, if you're revising for your exams and want more high-yield resources like this, do check out passthemsassery.com.
And for free resources and questions, head over to freemsessery.com.
Thanks so much for taking this deep dive into AAA with us today.
Been great talking it through.